Throw everything that you know about cholesterol out of the window. I'm willing to bet that you have not updated your understanding of cholesterol, everything from what affects it and how to interpret your labs and what labs you should even be getting and how often you should be having it checked. Because let's face it, chances are most doctors haven't either. Welcome to the Lifestyle MD podcast, the podcast dedicated to high-achieving women who are conquering their careers while striving for total wellness. I am Dr. Angela Andrews, and I am thrilled to be your guide on this journey. I'm Dr. Angela. Welcome to the Lifestyle MD. In this episode, we're going to get into the hot topic of cholesterol. There's been a lot of new research in the last 5 to 10 years around cholesterol. Some of it has made it into the guidelines and some of it has not. Some of those things are just as optional or nice to have things. Well, in this episode, I'm going to break that down for you a little bit further and tell you what you need to know. This episode is specifically for individuals looking for primary prevention. Primary prevention means that you have not already had a heart attack, a stroke, and you don't already have peripheral vascular disease. In this episode, I'm not only going to explain the function of cholesterol, but I'm also going to explain to you how to interpret your cholesterol numbers, which numbers matter, how you can lower your overall risk of cardiovascular disease, because that's really the point here. We want to prevent strokes, heart attacks, peripheral vascular disease. And even if you've already had a heart attack or stroke, or you have peripheral vascular disease, the lifestyle recommendations that I'm going to make will apply to you. What won't apply to you? Management choices. All right, let's get into it. So what is the role of cholesterol in your body? Cholesterol is a waxy, fat-like substance that is in every cell of your body. Cholesterol actually serves a very critical role. Your cells cannot function without it. Its functions include everything from building the outside protective covering of your cells, also known as the cell membrane. It's also used in the production of hormones, so everything from estrogen, testosterone, to cortisol. You need cholesterol to make vitamin D, and cholesterol is used to help you digest food. In particular, bile is composed of mostly cholesterol. Cholesterol is actually really important, but it's really gotten a bad rap because there is such a thing as having too much cholesterol. When we talk about cholesterol, we're actually talking about lipoproteins. So lipoproteins are the substances that transport fat or lipids in your bloodstream. There's several different types of lipoproteins that you've probably heard of. The most common is LDL, HDL, and triglycerides. So the LDL has been coined the bad cholesterol, and HDL has been coined the good cholesterol. I'm going to break that down a little bit further. I'm sure a lot of you have already heard explanations of this, but I'm going to get into that anyway. So by definition, lipids or lipoproteins are insoluble in the blood or water, and that's why you need to have them in these transport vesicles. Let's just consider them like little vehicles that help move things around your body. Lipoproteins come in a variety of different sizes, and each one of these categories of lipoproteins have a specific job and function. When we have our cholesterol checked, you get total cholesterol, LDL, HDL, triglycerides. Those are the most common things that are checked. There are some panels that will also show you VLDL and various ratios, which you can calculate manually if your report doesn't show it. There's also another calculation known as the non-HDL cholesterol. So what do all of these things mean? So total cholesterol, the term total cholesterol is actually a little bit misleading. Total cholesterol is the sum of HDL plus LDL and 20% of your triglyceride level. But there's a lot more to your total cholesterol than just those numbers alone. Dr. Peter Attia cleverly put it this way when he said that total cholesterol is just about as helpful as looking at eye color in terms of determining your risk of cardiovascular disease. Another similar number is your non-HDL cholesterol, which often shows up on lipid panels as well, is calculated by subtracting your HDL cholesterol from your total cholesterol. Again, marginally helpful because it doesn't take in consideration some of these other values I'm going to be talking about today. All right, before I can make sense of all of it for you, let's kind of do a more detailed breakdown of the lipoproteins that you need to be aware of. So there's chylomicrons, VLDL, also known as very low density lipoprotein, ILDL, which is intermediate low density lipoprotein, and then of course there's the LDL, which is low density lipoprotein. The final one is HDL, which is high density lipoprotein. The difference between each one of these lipoprotein molecules is their size and their density, hence why density is included in the name. So the largest one is chylomicrons and the smallest are the HDL in the order that I described them. And then in reverse order is the density. The chylomicrons are the least dense of the molecules and the HDL molecules are the most dense. The larger molecules contain the most amount of triglyceride. The smaller molecules, the HDL, contain the least amount of triglycerides. Okay, why does that matter? The job of chylomicrons is to transport lipids, or the fats, from your intestines, so things that you eat in your food, into the bloodstream. From there, it transports the lipids to your muscle, fat storage, and to the liver. Again, these are the largest and the least dense of all of the lipoproteins, and their job is solely the transport of dietary triglycerides and cholesterol and fat from the intestines to the bodily tissues. VLDL is made in the liver. Its main job is to transport triglycerides as well, along with just a tiny amount of cholesterol, and it takes these molecules from the liver out to the body. As it's circulating and losing triglycerides, so as it's dropping off its triglyceride cargo in various locations, it gets smaller in size and more dense. It is transformed into ILDL and eventually into LDL. LDL's job is to take cholesterol also from the liver, so as it goes from VLDL to ILDL all the way down to LDL, and deposit it in all the places in the body that you need it, and in sometimes places where you don't need it, like your arteries. So when you have an excess or more VLDL, ILDL, and LDL than you need, some of that extra cholesterol and triglycerides gets deposited in places where it doesn't belong, namely your arteries. The process of making HDL is different. It still comes from the liver, but it also comes from the intestines, and it's pretty clever. Its job is to carry cholesterol away from the arteries and away from the body back to the liver, where it can then be broken down and eliminated. Hence the term good cholesterol. I like to think of LDL as a delivery person whose job is to deliver cholesterol everywhere, and HDL as the garbage person whose job is to pick it up and get rid of it. Starting to make sense now? The reality is LDL has really just gotten a bad rap. It's just doing its job. The only problem is when it's in excess, and it's not LDL's fault. It's the human's fault. So to quickly summarize, HDL, chylomicrons, VLDL, ILDL, LDL, and HDL are all lipoproteins. Lipoprotein is just a molecule that contains lipids and proteins. The more protein the molecule contains compared to lipids, the more dense it is. Hence, HDL has more proteins than it does fat. That's it. Now remember, the job of all of the bad cholesterol is to transport cholesterol and fat to the body and to the body tissues and to the arteries. The job of HDL is to take it away and dispose of it. Now there's a couple other lipoproteins that I want to talk about that are really important, that I really want to encourage more people to get tested for. And also I want to encourage more doctors to consider testing it. The current guidelines don't routinely include it in testing, and we'll talk about that. But right now I just want to explain to you what they are. So the first one is apolipoprotein B. Apolipoprotein B100 specifically, it's called a carrier lipoprotein. It's attached to VLDL, ILDL, and LDL, and the chylomicrons. Its job specifically to behave as a receptor so that the cells in your body recognize those lipoproteins and allow them inside the cell. So without ApoB being attached, your body wouldn't know to take this cholesterol or take these lipoproteins up and put it in the cell. So what's interesting about ApoB, you might have noticed that it is attached only to all of the bad actors, so to speak, or all the delivery mechanisms of cholesterol to your body. So let's say you have a low LDL, but you have a high ApoB. That might mean that you have higher levels of all those precursor lipoproteins that ultimately become LDL. So it is a more broad measure of all of your quote bad cholesterol numbers. I'm just going to call them all bad actors because they eventually lead to LDL. The second bad actor that I want you to be aware of is lipoprotein A, also known as Lp(a). It is another type of LDL cholesterol, and this little guy actually attaches to the ApoB on the outside of these other lipoproteins. So ApoB is on VLDL, ILDL, LDL, and then Lp(a) attaches to the outside of that. Why the heck do we have Lp(a)? Well, its job is to make all of these particles stickier. So as a result, the more Lp(a) that you have, the more your cholesterol or these LDL particles will adhere and build up on your blood vessels. Research has actually suggested that Lp(a) is an independent risk factor for heart disease, independent of your LDL levels or any other cholesterol markers that you have. The unfortunate thing is, while you can actually improve your HDL and lower your LDL levels with diet and exercise and various lifestyle choices, there is very little that you can do to modify your Lp(a). You're essentially born with it. Lp(a) levels are 70 to 90% genetically determined. So that means that the strategies we have for preventing and reducing cardiovascular disease risk just don't apply to this number. This does not mean that you should not engage in healthy habits and have a healthy lifestyle. So exercise regularly, really eat whole foods, avoid sugar, and all the things. What it does mean is that you need to be much more diligent and very aggressive about your approach. To put it in more concrete terms, two people with the same LDL level and two different LP(a) values. So let's say one has a value of 10 milligrams per deciliter of LP(a) and the other has a value of 150 milligrams per deciliter of LP(a), but both of them have LDL levels of 100. The person whose level is 150 is going to be at a significantly higher risk of cardiovascular disease. So in other words, if you have a normal looking cholesterol number and you have an elevated LP(a), you still have up to a 3 to 4 fold increased risk of having a heart attack. So you get a statin, you get a statin, you get a statin. This is a category of people that I am much more likely to recommend a cholesterol lowering medication because we need to do everything in our power to lower your risk. These are the people that are more likely to have heart attacks in their 30s and 40s. It's estimated that up to 20% of the people worldwide have elevated levels of LP(a). But guess what? This is not something that we routinely check. There's not any concrete guidelines on what's considered low or high, but any reading above 50 milligrams per deciliter or 75 nanomoles per liter should be considered high and increases your risk of atherosclerosis, heart attacks, and strokes, in other words. Another note on this value, it is an acute phase reactant, so it can be excessively elevated during times of inflammation, but generally speaking, your LP(a) level is going to remain relatively stable throughout your whole life. It should not be something that changes. So this is not something that you need to get checked on a regular basis with your annual blood work. You just need to get it checked essentially once and assess what your level is, and then use the rest of your numbers to further mitigate your risk. All right, quick break here just to remind you that if you are enjoying our podcast and if you hadn't had a chance to subscribe, please subscribe. Share this with someone that you care about who might also benefit from this knowledge. So why does cholesterol matter? Why do we pay attention to it in the first place? This is something that most of us are familiar with, but I'm just going to briefly touch on it. So deposition of cholesterol inside of your arterial walls is caused by trapping of ApoB containing lipoprotein particles, so LDL specifically, and this drives atherosclerosis. Atherosclerosis leads to heart attacks. Atherosclerosis leads to strokes. Atherosclerosis leads to peripheral vascular disease, which increases the risk of things like lower extremity amputations. So what is the link? If you have too much LDL, then it can be deposited in the walls of your arteries, which then leads to plaque, which then leads to narrowing, which then leads to decreased blood flow, which then leads to all these other consequences. And the reality is our body is amazing. It is an amazing work of art. It has specific mechanisms to manage excess dietary cholesterol. So again, dietary cholesterol is not the problem. Your body will decrease absorption from the gut via the chylomicrons. It'll downregulate that, and it'll also downregulate the production of cholesterol from the liver. It'll stop making so much VLDL. But there's a problem. We can artificially upregulate our body's natural production of VLDL in the liver by consuming excess amounts of sugar. 85% of your total cholesterol numbers is produced by your liver. Your body is making it, leaving only 15 to 20% coming from your diet. Thought about talking about genetic factors that influence cholesterol in more detail, but right now I'll just leave it at the LP(a). There are some other genes and mutations that can increase your risk. So if you're someone who has a risk of having elevated cholesterol and cardiovascular disease because you have had other family members who have had heart attacks, strokes, other cardiovascular problems early in life, then you should make sure that your doctor is further investigating whether or not you have a genetic predisposition to elevated cholesterol levels. And if you are a physician, you should be asking your patients about these. Don't just look at their individual risk. We should all be considering what their familial risk might be. This makes up a small portion of the population, but still it is a significant enough problem, and it can be a huge life-altering event if someone has a major cardiovascular event early in life. So don't forget to ask. So the last thing I'm going to talk about in this episode is the latest science and literature and what we know about cholesterol and how to mitigate risk and how to manage it now and what numbers we should be targeting. In the next episode, I'm going to get into what you can do as an individual to lower your risk with and without medication. So we'll save that for a whole nother time. So how low does your LDL need to be? The answer is the lower, the better. How low does your ApoB need to be? The answer is the lower, the better. A recent review article that was published in the Journal of the American Heart Association, the physiologic basis for the superiority of ApoB over LDL and non-HDL cholesterol, said that ApoB is a much more accurate marker of cardiovascular disease. And since then, there has been ongoing research that has continued to support this notion. The other interesting thing about LDL measurements is that LDL is often calculated and not directly measured. So you might have seen terms like LDL-C or LDL LDLP. LDL-C is a measure of the amount of cholesterol contained in your LDL particles, and LDLP is a measure of the number of LDL particles. Now, not every LDL particle is going to contain the same amount of cholesterol. So you can see where actually measuring the cholesterol contained in your LDL is a much better measurement. But the reality is that the equations are also potentially inaccurate. The calculation for LDL can be thrown off by very high levels of triglyceride and even very high levels of HDL. So why don't we just directly measure LDL? Well, LDL measurements directly is very expensive and cumbersome. So that leaves us with a slightly less accurate tool using often something called the Friedewald equation. So knowing this and knowing that ApoB is potentially a much more helpful tool because it is giving you an indication of all of the particles, not just the LDL, you can understand why some of us might actually prefer measuring both ApoB and LDL. But here's what the current guidelines have to say about measuring cholesterol and calculating cardiovascular risk. The guidelines are designed to help address 4 groups of people. The first group of people is for secondary prevention for patients who have had known ASCVD risk, or in other words, they've already had a heart attack or stroke or some other cardiovascular event. The second group is for people who have severe hypercholesterolemia, such as elevated LDL levels greater than 190. The third group of people is for people who have what we call cardiovascular risk equivalents. So people with type 2 diabetes and maybe some other risk factors like they're smokers. These individuals are likely to benefit from intense lifestyle therapy and most likely also a statin in order to lower their cardiovascular risk. The fourth group is the group that I'm specifically speaking to, and this is the primary prevention group. Individuals who have not already been diagnosed with diabetes, who have not already had a heart attack or a stroke, or any other cardiovascular disease equivalent. These recommendations come from the 2018 guidelines on the management of cholesterol. This is an update from the 2013 guidelines on diagnosing, treating, and monitoring cholesterol. When I dived into these guidelines, I was really curious to see what they said about apolipoprotein B and lipoprotein A. And this guideline specifically addressed both of these measurements, but did not include it as part of its standard recommendation. I also looked at the AAFP guidelines for CVD risk screening, and their guidelines neglected to mention apolipoprotein or lipoprotein A at all. So I will say that the 2018 guidelines did point out that there is unreliability associated with the Friedewald calculated LDL-C levels. And then if that an accurate measurement of risk is needed, or a more accurate measurement of risk is needed, then measurements of ApoB may be useful in determining whether or not hypertriglyceridemia is atherogenic. So in other words, if you want to get a better assessment for someone's atherosclerosis risk and you're not certain about the accuracy of their LDL measurement for whatever reason, then you should consider getting ApoB. Again, it's not a recommendation for the standard guidelines, but it is mentioned. So what are the standard guidelines for primary prevention according to this 2018 report? First of all, it says you should assess ASCVD risk in each age group and emphasize adherence to a, quote, healthy lifestyle. Again, it doesn't actually get into details of what healthy lifestyle is. I will talk about that in my next episode, what we actually know about the guidelines around healthy lifestyle. There's a little bit of controversy with that, although I feel like it's becoming less controversial as more information comes out. But from ages 0 to 19, lifestyle to prevent risk. And if someone has a family history suggestive of a familial hypercholesterolemia, then you should do additional testing, genetic testing, cholesterol levels earlier, and actually even consider statin therapy, especially if there is a genetic predisposition. Because again, if you have a genetic predisposition, your lifestyle is not going to change that. For ages 20 to 39, the recommendation is that you can estimate someone's lifetime risk based on family history, their measured LDL level, and any other cardiovascular disease risk enhancing factors they may have. They are too young to use the ASCVD calculator, but you can look at whether or not they have a history of premature heart attacks and strokes. Premature meaning they've had a cardiovascular event before the age of 55 in men and before the age of 65 in women. Measuring whether or not they have had persistently elevated LDL-C levels of greater than 160 milligrams per deciliter or 4.4 millimoles per liter. Chronic kidney disease, metabolic syndrome, conditions specific to women such as preeclampsia, premature menopause, inflammatory diseases, rheumatoid arthritis, psoriasis, even HIV. If you have any inflammatory condition, your cardiovascular disease risk is inherently higher because cardiovascular disease is at its root an inflammatory disorder, and certain ethnic factors. So South Asian ancestry, you're going to have to look at much lower cutoffs for things like LDL, like BMI, like waist circumference, and when you're assessing risk. So you have to make sure you take that into consideration as well. There's some other measurements that you can look at. Again, these are the ones that I routinely recommend, and that is a high sensitivity CRP, LP little a level, ApoB, ApoB, and you can also consider acrobrachial index. I pretty much only look at that if someone's got symptoms or that I'm really trying to ascertain risk and we're not 100% sure. So if you are in the category of ages 40 to 75, the guidelines recommend if your level of LDL is greater than 70 and you don't have type 2 diabetes or type 1 diabetes, then we should calculate your 10-year ASCVD risk score. And then your risk discussion and treatment recommendations are going to be based on that calculation. So less than 5%, you're low risk, lifestyle only. 5 to 7.5%, borderline risk, lifestyle only. Consider medications, but continue to monitor more closely. 7.5% to 20% is considered an intermediate risk. And then greater than 20% is the highest risk group. And you're strongly recommended to initiate a statin right away. In all of these categories, if you are not certain about someone's risk, so let's say someone's high risk, you're like, oh, you know what, I don't want to go on a statin. Or like you're a provider who's like, you know what, I'm not sure that a statin is right for you. No one in your family's had cardiovascular disease. You've got no other risk factors that suggest that you might have cardiovascular disease. You may not have a risk of cardiovascular disease that is reflective of your score. You can do a coronary calcium score. Coronary calcium score is a great way to more accurately ascertain someone's risk, irrespective of what these calculations show you. And a score of 0 means that you have low risk and you really don't need to be on a statin. Further evaluate the risk based on any numbers right after that. Because I have a strong family history of premature cardiovascular disease. My father had his first heart attack in his 40s. His mother died from complications of multiple conditions, not the least of which I'm sure was diabetes and cardiovascular disease, all before the age of 50. So I inherently am concerned about my personal risk. My cholesterol numbers haven't been historically great. They're pretty good now. Actually, I probably should get another cholesterol test done. I'm a little overdue for that. So I wanted to know what my coronary calcium score was. I'm 43 years old, got my coronary calcium score. Fortunately, my score was 0. That's wonderful. But that doesn't mean I'm in the clear. I still need to be diligent about watching my lifestyle and making sure that I am doing a good job taking care of myself. So these guidelines are heavily dependent on age, an ASCVD risk calculation score, and other risk factors in order to determine your risk. Only when you cross a threshold or there is suspicion or possible concern for looking further do we typically in healthcare measure things like high sensitivity CRP, a lipoprotein A, and ApoB. I have started ordering these in pretty much all my patients or anyone who's willing to allow me to order it, I guess, because it may not always be covered by insurance, but I'll tell you what, the cost is relatively low when you consider the grand scheme of things. Everyone, I think, should at least have a lipoprotein A measured once because that's all you need to have it measured. And a lot of people may have metabolic disease or insulin resistance and have early risk factors for cardiovascular disease and not know it because no one's checking. What you don't realize and what a lot of people don't realize is that the signs of diabetes can be present up to 10 years before diabetes occurs. So that means that we're waiting for someone to get sick before we actually do something about it. So my recommendation is to get ahead of the game. Be proactive, be preventive. Go ahead and measure your high sensitivity CRP at least once. Measure lipoprotein A at least once. Get an ApoB level so you can correlate that with your LDL and see if your LDL actually is a good reflection of your cardiovascular risk. If it's discordant from your ApoB, well, then you have to question whether or not your LDL is going to be adequate in order to determine your cardiovascular disease risk long term, whether or not you should be monitoring your ApoB in addition to your LDL over time. I just think it's common sense. It's really not that expensive. You know, the guidelines don't recommend it because it doesn't want to add cost across the board. But how much more cost are we avoiding and more debility could we be avoiding if we actually predicted these things much earlier? Based on the current evidence, ApoB is increasingly being favored as a more accurate tool in a lot of ways to assess your cardiovascular disease risk. All right, that's pretty much it for this episode. I know that was a lot. It was really dense. I'm hoping the next episode will be a little bit more easy to digest, but I really want you to tune back in because I want to specifically talk about what lifestyle measures you should take. Every guideline, I don't care who made it, at the top of that guideline is going to be lifestyle modifications, but the lifestyle modifications are very broad. It tells you to work on a healthy diet, increase physical activity, manage your weight, stop smoking. Okay, hard stop, don't smoke, cut smoking, period. Okay, I'm done with that one. And then there's like little handouts and toolkits and whatnot you can share with your patients, but that's just not enough. There's so much more to a healthy lifestyle than what we're able to do in a traditional healthcare practice. The healthcare system is not currently designed to actually be proactive and to be preventive. The healthcare system right now is designed for sick care, for acute care. So it's not equipped to help prevent people. It's really only equipped to help diagnose problems. So at minimum, so if you're working with a traditional healthcare provider and you're not getting those detailed recommendations on how to improve your lifestyle, well, good news is you don't necessarily need that information from a doctor. It's what I do, but you don't need that from a doctor. But what I'm hoping to help you is in this next episode, get into practical, concrete tips. Not only how do you reduce your cardiovascular disease risk, not only how do you lower your LDL and your ApoB, but just how do you be healthy and have better longevity and better better quality of life. I talk to my patients all the time about improving those last 10 years, regardless of how long you live. Do you want those last 10 years of your life to be full of stability and to be incapable of doing basic daily functions, driving, walking, spending time with your grandchildren, whatever those activities might be? How do you want to spend those last 10 years? How you live your life now is going to determine that. So it's not just about cholesterol. This is just one measure. That's what I'm focusing on right now. It is a metric that can be extrapolated into other aspects of your health. And that's what I'm here for. So I really hope that you guys got something out of this episode. And if you have any other questions or you want me to talk about any other topics, definitely reach out to me. You can email me at angelalifestylemd@gmail.com. I am always looking forward to discussing topics that are going to be helpful to you. And yeah, all right, that's it, guys. Have a great one. Bye.